You can achieve an erection during foreplay without major difficulty. Everything seems to be working. But then during intercourse, sometimes within seconds, sometimes after a few minutes, it softens and fails completely. This specific pattern, where function works initially but collapses during activity, reveals dynamic compression that most men never identify. Your enlarged prostate isn't just blocking blood vessels statically. During physical activity, pelvic pressure increases dramatically, and that additional pressure on already swollen prostate tissue intensifies vascular compression to the point where blood flow becomes insufficient to maintain erection. What works when you're relatively still fails when physical exertion increases pelvic pressure. Here's the mechanical reality creating this pattern. At rest or during gentle foreplay, your cardiovascular system can deliver adequate blood flow to erectile tissue, even with moderate prostate enlargement compressing nearby vessels. The compression restricts flow somewhat, but not enough to prevent initial engorgement. Blood accumulates slowly, erection forms, everything appears functional. But intercourse changes the equation completely. Physical exertion increases core body pressure. Pelvic floor muscles contract repeatedly during thrusting. Abdominal pressure rises. All of this additional pressure gets transmitted directly to your already swollen prostate, which then compresses blood vessels even more severely than it does at rest. Think of it like a garden hose that delivers adequate water flow normally, but when you step on it, flow reduces to a trickle. Your prostate is that hose. At rest, it's compressed somewhat, but flow is adequate. During intercourse, the physical activity essentially steps on that hose harder, crushing it further. Blood that was flowing adequately can't maintain sufficient pressure against the increased compression. The erection that formed under lower pressure conditions can't sustain under higher pressure conditions. This explains the devastating pattern of failure at the worst possible moment. You're engaged, your partner is responsive, intimacy is progressing, then suddenly function disappears. The psychological impact compounds the mechanical problem. You start worrying during foreplay whether you'll lose it again. That anxiety creates tension that further increases pelvic pressure, making failure more likely. The anticipation of failure becomes partially self-fulfilling because stress physiologically worsens the compression problem. Your partner experiences profound confusion and hurt. They see that you achieved erection initially, so they know you're attracted and interested. But then it fails during the act itself, which feels like rejection or inadequacy on their part. They don't understand you're experiencing dynamic vascular compression that intensifies with physical activity. Some partners try different positions thinking angle or depth is the problem. Others slow down or reduce intensity, which might help slightly, but can't overcome severe compression. Many eventually avoid initiating intimacy because the repeated pattern of starting, then stopping, becomes emotionally painful for both people. The progression pattern is particularly cruel. When this first develops, maybe you lose erection after 10 or 15 minutes of activity. That's frustrating, but at least intimacy is possible briefly. But as prostate inflammation worsens month by month and the gland swells larger, the activity-induced compression becomes more severe, more quickly. What used to work for 15 minutes works for 10, then 5, then 2, eventually failing within seconds of beginning intercourse. You reach a point where even attempting becomes pointless because you know the pattern will repeat. This is educational information about vascular mechanics during physical activity. It helps explain what you're experiencing but doesn't replace medical guidance. Most men dealing with this pattern try approaches that don't address the dynamic compression. They attempt slower, gentler intercourse, thinking reduced exertion will help. That might extend the window slightly, but can't overcome the fundamental problem of pressure intensified vascular restriction. They try medications that force vasodilation, which helps somewhat by maximizing whatever flow capacity exists. But medications can't remove the physical compression that worsens with activity. Some avoid positions requiring significant exertion, but prostatic compression affects all positions because pelvic pressure increases during any intercourse regardless of specific mechanics. Here's what happens if prostate enlargement continues creating this dynamic compression indefinitely. The threshold for failure keeps shortening. What currently fails after 5 minutes will fail after 2 minutes within months. Eventually, you reach a point where even achieving initial erection becomes difficult because your brain learns to associate attempted intimacy with inevitable failure. Psychological erectile dysfunction develops on top of the mechanical dysfunction, creating a combined problem harder to resolve than either alone. So what actually restores the ability to maintain erections during activity when prostatic compression is the cause? The only approach that works is reducing the prostate inflammation, creating the compression. When chronic inflammation in prostate tissue decreases, the gland shrinks somewhat. When size reduces, baseline compression on blood vessels decreases. When baseline compression is lower, the additional compression created by physical activity during intercourse doesn't reach the threshold that causes vascular failure. Blood flow that was barely adequate at rest and insufficient during activity becomes adequate for both. Most men who properly address prostate inflammation notice this pattern improving in recognizable stages. The first change typically appears around week 8 to 12 as prostate size begins reducing. Erections that failed within 2 minutes might sustain for 5 minutes. Still not ideal, but movement in the right direction. By week 16 to 20, as inflammation continues decreasing and vascular compression continues easing, many men report sustaining erections for 10 to 15 minutes during active intercourse. The dynamic compression still increases somewhat with activity, but not enough to cause immediate failure. By month 6 to 8, when inflammation has been substantially reduced, most men find they can maintain function throughout intercourse without the previous pattern of mid-activity collapse. This requires comprehensive intervention targeting prostate inflammation while supporting vascular resilience simultaneously. Natural compounds that reduce swelling in prostate tissue so baseline compression decreases. Ingredients that improve vascular elasticity so blood vessels resist compression better. Support for nitric oxide production so vasodilation capacity maximizes. Circulation-enhancing nutrients that optimize blood delivery under physical stress. When all of these work together, you're reducing the compression while strengthening the vessel's ability to function despite remaining compression. Expectations need to be realistic about the timeline. This won't restore instant function. The first months show incremental improvement in how long you can maintain erection during activity. But those incremental improvements compound. Going from failure within 1 minute to sustained function for 5 or 10 minutes makes intimacy genuinely possible again, rather than an exercise in anticipated disappointment. The mechanical barrier preventing sustained intercourse is progressively removed. There's information in the description about a comprehensive approach designed to reduce prostate inflammation while supporting vascular function during physical activity. When compression is properly addressed, the ability to maintain erections during intercourse typically improves progressively, with most men seeing substantial improvement over 16 to 24 weeks. How long can you typically maintain erection during intercourse before it softens?